to talk on acute and chronic Tendoachilles ruptures. This is an introduction about it. The Achilles tendon is one of the most commonly ruptured tendons of lower extremity. And chronic Tendoachilles rupture is defined as the ruptures that occurs in 4 to 6 weeks after injury. This is something like this. There's a break where your foot and ankle mechanism doesn't work when you don't have this Tendoachilles and connectivity. Basically, a simple classification of the Tendoachilles, open and the close. Open is in our country, which is very common. This is a closet injury, usually in the Indian type toilet, where their foot gets stuck inside and they try to take it out. Either this thing breaks, the closet breaks, and it cuts exactly on the Tendoachilles. And there's a closed one. This is acute in case of athletic injuries, and neglected, that is degenerative when you have a tendinitis, peritendinitis. This one happens. Mechanism of injury, like you just see his right foot, how this one happens. You can understand in a better way. Like pushing off with weight-bearing forefoot. You can see his forefoot there, and the knee in extension. And sudden unexpected dorsiflexion of the ankle, you can have a snap on that Tendoachilles. That's how it commonly happens. Or a direct blow to the contracted tendon, or a laceration, a violent dorsiflexion of the plantar foot, as how it happens on a fall from height. This is the mechanism. And Tendoachilles rupture risk factors. Most common in middle-aged athletes, previous tendon disorders like tendinitis, tendinosis, peritendinitis, and age group is 30 to 40 years. Men and women equally affected, and post-steroid injection for retrocalcaneal bursitis, and drugs like quinolones. These are the common ones. And you generally say the weekend warriors, where they go for a sports activity in the weekends. That's quite common in these individuals. And what happens in chronic Tendoachilles rupture? Chronic Tendoachilles, there's a large gap defect in the Tendoachilles. Defect is filled by scar tissue and weakens the ankle joint and strength of the plantar flexion, and thereby an ankle dysfunction and gait disturbance. Problems in chronic Tendoachilles rupture: large gap defect, scarring of the surrounding tissue, retraction of the calf muscles, and loss of contractibility of the triceps array. Clinical features: patient usually complains of pain in the ankle, fatigue, ankle stiffness, walk with a limp, unable to run, climb stairs, not able to stand on tiptoes, and loss of plantar flexion power. On examination, patient lying prone with feet over the edge of the foot, palpable defect in Tendoachilles and tendinitis, and normal, you can see there, the defect, and there's a normal Tendoachilles. This Thompson test, sir, as Dr. Kamal sir has spoken about it in the morning, where you squeeze it. In a normal one, it goes for a plantar flexion. In the lacerated one, you don't find that. In the radiograph, avulsion, fracture at the insertion with mark, everything, you can see calcification of the tendon in case of tendinitis. And ultrasound is a very inexpensive simple mode of methodology to identify. It's fast, reproducible, dynamic examination possible, best to measure thickness and gap, good screening test for complete rupture. MRI is a useful tool for diagnosing Achilles tendon rupture, assess the integrity of the Achilles tendon stumps, assesses the size of the defect in Tendoachilles, and post-operatively acquire the information of Achilles tendon healing. You can see the defect there in that MRI. And management of Tendoachilles rupture. Goals of treatment: optimize gastrosoleus strength and function, restore muscular tendinous length and tension, and avoid ankle stiffness. Conservative management is a little controversial, and this is how it is done. Cast in plantar flexion for 2 weeks, and then a cam walker or a cast with plantar flexion, a little decrease in the plantar flexion at 2 weeks, and that is kept for 4 weeks. And allow progressive weight bearing in removable cast, and that is for another 2 to 4 weeks. And after that, you remove the cast and walk with shoe lift. Start with 2 centimeters for 1 month, and then for 1 centimeter for 1 month, and then discard that. But there is a 40% re-rupture rate is possible in this. Surgical management principles: preserve anterior paratenon blood supply, protect the sural nerve, debride and approximate the tendon ends so that it heals well, and close the paratenon separately on the repaired tendon. I've just made a small tabulation of this operative tendoachilles rupture. Defect of 1 centimeter or less, direct end-to-end repair without augmentation is possible. Defects of 1 to 2 centimeters, muscle mobilization with augmentation. You can grab the proximal end of the tendon and give a constant traction for at least for a minute. Usually, you'll be able to augment it in this level one. And defects of 2 to 5 centimeters, VY-plasty is a better option. And defects of 5 centimeters and above, tendon transfer to augment the gap. The defect of either you have to use a FHL or a turn down or a semitendinous one. Conservative, no role of conservative in chronic tendoachilles rupture. Direct end-to-end repair, there are many techniques, Bunnell suture, modified Kessler's, and many techniques are available for this. Muscle mobilization with augmentation with plantaris tendon is one thing. And this is a VY-plasty. You can see there on the, it's like an inverted V. And at the muscular tendon junction, you have to do this. And as you strip it forward, you will close it like a Y. This is for the FHL transfer for tendoachilles rupture, where you augment with the turn down as well, along with the FHL tendon. Why FHL? Because it is close to the Achilles tendon and same function as triceps surae, and it has an adequate strength and same axis of moving with tendoachilles. There is a study by Ockensen et al. Reported that mean hypertrophy of 52% of the FHL muscle after FHL transfer in chronic tendoachilles rupture in MRI. See, this is the FHL harvesting. Can you see this is the master knot of entry where you go and harvest your FHL tendon if you want a small graft. If you want a long, lengthy graft, then you have to go at the base of the TPX of the great toe. There you have to take the double one. This is a double incision and taking of the double graft where you loop it around like this and stitch on it. Loop it on the calcaneum and get back like that. I'm going to show you some few cases. This is a 45-year-old male presented with complaints of difficulty in walking and running, 6 months duration. On examination, palpable defect in tendoachilles and tendinitis, inability to stand on tiptoe, and Thompson test positive. This is the defect after excising the scar tissue. This is a case of a chronic tendoachilles rupture. This is huge gap. This is by means of a turn down. But it was tendoachilles was reconstructed. And this is option. This is one of our earlier cases. And this is a 55-year-old woman with chronic tendinitis of tendoachilles, presented with complaints of difficulty in walking for 12 weeks. Palpable gap in the tendoachilles, not able to stand on tiptoe. This is a midline incision. You can see there is a chronic tendoachilles rupture. This is after debriding. You can see there's a gap of 7 centimeters. So this is the FHL brought down there and fixed by means of a tenodesis screw. This is Dr. Ajoy's case. I thank him for that. The case 3, this is a 60 years female, sustained injury to ankle 7 months back, trivial injury, diabetes and hypertensive, on exam defect in tendoachilles and not able to stand on tiptoe. You can see the right ankle there. There's a defect.
2 minutes left.
After debridement. Yes, this is a semitendinous graft which was harvested and brought down and fixed. Rehabilitation protocol for tendoachilles rupture, 0 to 4 weeks. Posterior splint, non-weight bearing with crutches, 4 to 6 weeks. Air cast walking boot with 2 centimeters heel lift, protected weight bearing with crutches, active plantar flexion, dorsiflexion to neutral inversion and eversion below neutral. 6 to 8 weeks, remove heel lift from boot, weight bearing as tolerated, dorsiflexion, stretching slowly, graduated resistant exercises, proprioceptive and gait training. 8 to 12 weeks, wean off boot, return to crutches and gradually wean off, continue to progress range of movement, strengthen and proprioception. 12 weeks, retrain strength, power, endurance, sport specific training, prevention of re-injury, good conditioning and proper stretching before running, adequate warm-up, adequate rehab, good fitting shoes. Take-home message, acute tendoachilles rupture, operative treatment for the young, athletic, higher demand patient, consider treatment for those patients with limited functional goals or medical comorbidities. This is for chronic tendoachilles rupture. Take-home message, management depends on the patient's age, demand and size of the defect. No role of conservative management. Earlier the management helps to prevent ankle dysfunction and gait disturbance. Thank you.
Perfect. Perfect. Parthiban, really stuck to time, to be honest. Thank you so much, Parthiban. Fantastic coverage of the whole topic within the 10 minutes, which I know is very difficult, and you've shown some great cases as well. Can I